Hello everyone. Welcome to the
Yes,
White Army Comprehensive Clinical class. Today we have with us Professor Srinivasan sir from Coimbatore Medical College as the mentor for the session. Welcome sir.
yes.
The surgical case of benign breast disease is presented by Ms.Lekhana, third year MBBS student from BGSGIMS, Bangalore. Uh, let's begin the session. Over to you, Ms. Lekhana.
Yeah, thank you. Good evening, sir, and to all who've joined us today. I'll thereon be presenting the case. I present to you a case of a 21-year-old unmarried female law student named Miss KLM from Vijayanagar, belonging to an upper middle class socioeconomic status, who had come into the OPD at 12 p.m. on the 11th of August 2020, accompanied by her mother, with the chief complaint of a lump in the upper outer aspect of her left breast since 3 months. History of presenting illness. The patient was apparently normal 3 months back when she first noticed a small, movable lump in the upper outer aspect of her left breast while taking a bath. The lump had remained the same for the last 2 months and in the last 1 month had increased to the present size. The lump is not associated with any pain, normally or during menstruation. She gives no history of a previous pain around the same area, which was treated with antibiotics. No history of any recollectable trauma 3 months back, no history of fever. She has no complaints of discharge of blood, fluid, pus, or milk from the nipple. No history of loss of appetite or weight loss. There is also no history of pain at the back, hip, or shoulder, dyspnea, chest pain, jaundice, headache, or seizure. No history of OCP or hormone replacement therapy. No history of irradiation. Past history, no history of similar complaints in the past, no history of diabetes, hypertension, asthma, tuberculosis, etc. No history of trauma, no history of previous surgeries and previous biopsies, no history of allergy to any medicine or diet, no history of any drug intake. Personal history, diet is mixed, appetite normal, sleep normal, bowel and bladder movements are normal, no addictive habits, she's unmarried, there's no lactational history. Menstrual history, age of menarche at 13 years, duration of her menses is around 4 to 5 days. Regular monthly cycles, no history of passing clots, no history of dysmenorrhea, no history of breast pain during menses. Family history, no history of breast cancer or related deaths in the family, no history of breast cancer in the first degree relatives, no history of endometrial, cervical, ovarian, pancreatic, or colorectal cancers. So, on the basis of history taken, the probable differential diagnosis could be fibroadenoma, low-grade phyllodes tumor, and papillary cyst adenoma.
Excellent
Yeah,
presentation, Lekhana.
yeah.
Excellent.
You stop there.
Mm.
Your presentation was excellent. Beautiful presentation. You mentioned about thing. When you come to your profession, you just summarize in your history. Okay. On the
Okay.
basis of the history taken, the probable diagnosis could be a benign lump. That is enough.
Okay.
Okay. Lekha, what's your name? Lekhana.
Lekhana, yes, sir.
Yeah. So that is enough. You need not bring all this in your history.
Okay.
On the basis of the history taken for so a 14-year-old male, unmarried male, female
Mm, mm,
with 3 months lump duration, with all
mm,
the histories, you say it could be a benign tumor. That is enough.
mm.
These things should come at the end of your clinical examination.
Okay.
Now, can we go to the first slide?
Yes, sir.
Ishan,
This one,
correct
sir.
me if I'm going
Yes,
wrong, okay?
no, I am also learning, sir. I am from you.
No. No. We learn from you. Now, what is the importance of telling an unmarried, you can say unmarried female, it's enough, for 21 years, unmarried female.
Mm.
Okay. What is the importance of marriage and breast lump you want to know?
So once they are married, meaning if they have children, they would have breastfed the child. So
Okay. So that is okay. Now, this OPD at 12 p.m. on the 11th of August, accompanied by other. That's all. I think it's a different institution, different ways. I'm not going into the detail. Lump in the upper outer aspect of the breast for the 3 months. Go to the next slide. So she noticed a movable lump in the upper outer aspect. What is the importance of the upper outer aspect,
Um,
Betty?
yeah, sir, in the upper outer aspect quadrant, we have the axillary tail of Spence, and it's also the most common site for fibrocystoadenosis and also.
Not system, mostly carcinoma occurs in the upper outer quadrant, isn't it? Huh?
Yes, sir.
So,
Why
how
do
much
you
breast?
think it's common there, Lekhana?
Sir, it's because it's closer to the axillary lymph nodes, sir, mainly to the anterior group.
No, more
No.
than that, there are more of breast tissue in the upper outer quadrant. How many quadrants you have there in the breast?
So there are 4 quadrants.
No, 5. Central compartment, central nipple areal complex is the center also you can take. Okay. Yeah, somebody has mentioned it 5. Now, a brief anatomy of the breast. What type of gland is breast?
So it's a modified sweat gland.
Where does it develop?
So from the ectoderm.
Which month or week?
6th week, sir.
Very good, very good. How does it develop?
Sir, it forms the primary nodule and then the secondary
It's
nodule.
ectodermal thickening extending from the axilla into the groin.
Into the groin.
During the pregnancy. And the 8th month, all others disappear except the ectodermal thickening in the pectoralis area remains the same. Okay, remains persistent and it develops into the breast cancer. So, how does the breast composed of? What is the breast composed of?
So it's got fat, it's got stroma, glands, ducts.
Yes. How many?
Mainly 2 types of tissue.
Sir?
What are the mainly 2 types of tissue it's composed of?
Glandular tissue and stromal tissue.
Just go ahead, Kishan.
Yeah, it's what about the epithelial component?
The glands, sir. The glands.
Okay.
It is the parenchyma and the stroma. The parenchyma contains of the lobules, which comes as the lobes, then which are connected by the fibrous septa in between. These things attach them to the skin that is called the Cooper's ligament, which is called the suspensory ligament of the breast. From this only you have the ducts. Around 10 to 15 to 20 ducts are draining into the tip of the nipple. The nipple has got multiple orifices, all open into the different orifices. Then you have the areola. Areola is nothing but a thickening which has got the Montgomery glands, which is nothing but a lubricant to the nipple areola complex. Okay. So, can you tell me about the blood supply? Just briefly. Since you are a third year student,
Yeah, sir, it's supplied by the lateral thoracic artery, which is a branch of the axillary artery, and also from the branches of the internal costal arteries.
intercostal arteries.
Intercostal arteries, and then through some cutaneous branches from the subclavian artery as well.
Perforating branches of the internal mammary artery. You get it, okay? So the drain is the corresponding veins. It drains. Now, what are the lymph nodes?
Sir, it would be the axillary lymph nodes. No, it's divided into 3 levels. Level 1, 2, and 3. By the pectoralis minor.
Very good. Yes. What is that level named as?
Sir, level 1 is below and lateral to the pectoralis minor.
Yes.
Level 2 is behind the pectoralis minor, and level 3 is above it.
Yes, that classification is called Berg's classification. BERG, Berg's classification. Okay, this is in brief. Okay. Now, is breast a superficial gland or a deep gland?
It's a superficial gland.
Any part which is deep, you know? You said just mention.
Any deep?
One part of the breast goes deeper, pierces the deep tissue and goes to the deeper aspect. What is that? You mentioned.
So that's the
Something in
axillary tail of Spence.
Yes, it goes through the foramen of Langer and becomes deep.
Langer.
Okay,
for
fine with your anatomy and anything. Now you said lump is in the same size for the 10 months. For the past 1 month, it has increased into the present size. Good. So there is no rapid increase in size. Okay, that is one point. For
why it's important, rapid increase in size. What does that signify?
Sir, it signifies towards carcinoma, sir.
Anything else? Benign also. Can anything progress fastly?
Any inflammatory condition?
No, it remains usually static. It doesn't progress like this for 3 months. You mentioned in a provisional diagnosis. That's why I'm asking you.
Phyllodes, sir.
Yeah, good.
yeah,
Okay.
relax. Yeah, then lump is not associated with any pain. Now tell me, can you tell me the at least 2 or 3 causes of painful lumps in the breast?
So painful lump, one being fibrocystoadenosis, then the other being
Fibroadenosis.
acute mastitis,
Yes.
then the other being TEEDS syndromes,
Carcinoma.
carcinoma as well.
Carcinoma is again a
What?
painful condition. Okay.
State syndrome, you told.
You said
Yes,
teach.
sir.
What's teach? What's teach syndrome?
Sir, it's second and third costochondritis.
Costochondritis.
Musculoskeletal pain. Okay, that's also can be confused with the pain from the breast. Good. You should know
That's
this.
a very good
It's
one.
rare.
Now you said syndrome. I'll ask you what is Poland syndrome?
Yeah.
So Poland syndrome is associated with amastia, and the sternal head of the pectoralis major group is
Very
also
good, very good. You said external head. Very good. Absence of the pectoralis major with amastia. What is the absence of nipple called?
athelia.
Very good, very good. So multiple that congenitally, if you have multiple breast, it's called multiple accessory breast. What is it called?
Polymastia.
Polymastia. Where do you get usually?
So in Fletcher syndrome.
No.
Along
In
the line.
which location? Location. Sir is asking.
Sir,
The
it's
descent.
along it's along that line of Schultz, that milk line, along the
Yeah, milk line. What will be the typical if there is an accessory breast present? What will be the typical complaint the patient will come to you? You say yes or you say don't know. I will explain. No
I
problem.
don't know, sir.
Yeah, the swelling will increase in size and become painful during menstruation, because that is also a part of the. If it is really an accessory breast, it will have increase in size and increase. There will be pain during menstruation. Okay. Suppose the axillary fold, you will have a lump, anterior axillary fold. It may be a lipoma or an axillary breast, unless and until you have to differentiate clearly by pathological examination, or it could be a plain lipoma. That is why. So no history of previous pain. Go to the next slide. Why you ask for the history associated with pain during menstruation? What is the term called?
So cyclical mastalgia.
Kishan, since she's a third year, I am going step
Yes,
by
sir.
step. Okay.
No, perfect,
Is it
sir.
okay?
Perfect. She's answering very well. I am doubting
Yeah.
whether she's a third year UG or third year PG now. I'm getting a doubt now.
That I have to.
She
We have
just
to
told
go.
third year. She didn't tell third year UG or PG, sir. No. Okay. In which condition we get that cyclical mastalgia?
Sir, in fibrocystoadenosis.
No, don't get confused. Okay. It is fibroadenosis. Fibrocystadenosis is more like you're getting confused with phylloids. Okay. Just tell fibroadenosis. Okay.
What is the other name for it?
No, now all those terms have been replaced by the term Andy. What is that Andy?
Sir, it's aberration of normal development and involution.
Very good. So cyclical mastalgia, this fibroadenosis actually occurs during the time of evolution and involution mostly. Okay, that is at the time of menopause or at the time of menarche and menopause. Now, go to your next slide. No history of recollectable trauma is not. No history of trauma, you said. What is the importance of trauma in breast?
Sir, we could actually suspect traumatic fat necrosis.
Yeah. That is one. Number one actually is the trauma, history of trauma brings the attention of the patient to a lump which was existing previously. Okay. So then again, then she may note a lump. That is already the lump would be there. Trauma will bring the attention of the patient to feel the lump. That means you have to be careful. If a lump develops after a few days or a few weeks, based on the intensity of the trauma, you may get a traumatic fat necrosis, which is hard in consistency, which will simulate malignancy, because that are one of the causes for hard swellings of the breast. Okay. Yes. Okay. Can you tell me any other hard swelling of the breast? One or two?
So serous carcinoma.
Carcinoma, yes.
And it should be called
antibioma.
Sir?
Antibioma.
Antibioma.
What is antibioma?
Sir, antibioma is when there was a previous mastitis which was being treated by antibiotics.
Abscess.
I mean the abscess, which was treated by antibiotics, but it was not drained or nothing was done surgically, and eventually it's developed into an antibioma.
Organized mass and gets calcified there. Okay.
Okay, now come to you said no history of fever because of any mastitis. Okay, can you name some disease which produce mastitis? One is acute mastitis, inflammation of the breast. Any other things, chronic mastitis?
So if it's tuberculosis of breast.
Yes, good tuberculosis. Very rarely you may get actinomycosis. Sometimes, okay. No history of complaints of discharge of blood, fluid, pus or milk from the nipple. You can just say no history of discharge from the nipple. That is enough. Okay. Now the question will come, what are the discharges you know?
Okay. So it would be blood again, pus and milk.
What the type? Sir is asking simple. What are the types of nipple discharges and what they indicate of? What are indicative of? If it's a bloody discharge, what does that indicate? If it is serous discharge, like that, can you give some 3 for example?
Yes, sir. If it's a bloody discharge, it could be ductal papilloma or any other cancer. If it's pus, again, it could be mastitis. If it's milk, abscess. If it's milk, galactoria, galactocele seen during lactation. And if it's a serous, if it's like a greenish serous mass, it would be in ductectasia.
Okay.
And even in fibroadenosis also. Okay.
Serous discharge. Actually, the nipple discharge is classified as physiological and pathological. Okay. Physiological means you have these following points. You can note it down. It is bilateral, not spontaneous, not blood stain, multiple ductal discharge. Okay. Bilateral, multiple ducts, not blood stain, not spontaneous. Whereas if it's pathological, it is unilateral, spontaneous, bloody discharge, and it is from a single duct. Okay, so this is how the nipple discharge you have to classify, and you have them. So when we come to examination of the nipple, I'll tell you in mnemonics what are the changes you get in the nipple. So no history of loss of appetite or erection. So these are all just no history of pain at the back, hip or shoulder. Why are you asking?
Sir, it's in order to rule out any metastasis. If it was like a carcinoma.
Bony metastasis usually affects the spine, so at the back, and the long bones of the femoral head and the head of the humerus. Okay, these are the 3 common sites you may get in other place. Now you said dyspnea. Why?
Sir, if it would have included the pleura of the lung.
No, it produces classically a pleural effusion.
Pleural effusion, yeah.
Pleural effusion. Chest pain, okay, right, you, I cannot call because jaundice, yes, jaundice for why?
Sir, if it's metastasized into the liver.
Metastasized to the liver. How does it go into the liver?
So through the lymphatics only, sir, primarily through the subdiaphragmatic lymphatic group, and then it passes through the falciform ligament, and eventually it gets deposited.
Excellent. Transcelomic spread. Okay.
Yeah.
Headache and seizure, you said. Why?
Sir, it's because if the metastasis has gone to the brain.
Right. History of OCP, hormonal replacement, there's a contradiction. Now they say it is not producing any carcinoma of breast. Okay, but estrogens or hormone replacement therapy is not proved. There is keep on changing. But undergraduate, nothing wrong in it. Why you asked for irradiation? Because any previous
Sir,
malignancy,
if the radiation. Yeah.
previous malignancy, patient has been irradiated. Okay. So the chance of getting malignancy or the patient was irradiated for the same thing. Okay. Now go to the next slide. Kishan, you can add, Kishan.
Yes, sir. Yes, sir.
So no history of trauma. The past history, you have finished it. Now, what is the importance of asking of previous surgeries and previous biopsies?
Sir, this would be in order to rule out any recurrence, sir, like
recurrent.
recurrent
Which
fibroadenoma.
is recurrent usually, you say? Tell me two things which can recur. One or two things.
Sir, recurrent fibroadenoma or a
Yes,
recurrent
because
phyllodes.
improperly removed fibroadenoma, phylloid tumor. Phylloid tumor is more prone for recurrence. We will come to that later.
50%.
No history of it. Sir?
No, sir. Up to 50% recurrence chances.
Yes, it's not right. No history of any drug intake. Why?
So it's the same thing in order to rule out that OCP or HRT use.
Yes. Go to the next one. Diet. Okay, these are all lactation history. No, menstrual history. Age of menarche. What is early menarche, ma? They say early menarche. What is
it's
early
less
menarche?
than 12 years. When a girl is less than 12 years and she attains her first.
So 12 or 10, Kishan? Now 10.
12. They say early menarche is less than 10, sir, but less than 12 also, early menarche, some books say, sir.
Some is before 8 years. BT. Who is
No.
BT? No, it's 10. Let's don't say 8. It's regular monthly cycle. So she has got no problem with the menstrual cycle. Yes.
You
That we'll discuss in detail when we come. We'll come when we discuss about carcinoma. We'll come about these things.
Addictive habits you mentioned. You particularly you're interested to know about any specific addictions here?
So it would be alcohol intake.
Okay, and
smoking.
Any young girls? Yes, very good. Why?
So smoking, it's associated with TEDS syndrome also, and it's associated with carcinoma also, sir.
No, in young girls, in any other common condition, maybe benign condition, because of excessive smoking, and it's also another DD for this. That's why I want to rule out.
You mentioned.
Have you heard ductectasia? Have you heard ductectasia?
Yes, sir.
Okay, ductectasia is commonly seen in smokers. Okay, that's right.
Okay. What is the ductectasia, ma?
Sir, it's the dilation of the lactiferous ducts.
Shortening and dilatation of the lactiferous duct is called ductectasia. Okay, it comes shortening and dilatation. Yes. Go to the next slide. So this why this and all when we present the case of malignancy, we can ask about all these things. Okay. No history of passing clots, breast pain during menses. This is all you told. You said this is because of the cyclical mastalgia. Why? Family history. Yes. No history of breast cancer. This is a beautiful family history you have elicited.
Yes, sir.
That's you. No history of breast cancer in first degree relatives, and no history of endometrial, cervical, ovarian, pancreatic, and colorectal cancers.
For other members, this is how it should be written. Simply don't write nothing significant, we have this habit of writing past history, nothing significant, families, nothing. Don't write, which may not be significant for us. For the examiner, that may be the most significant, or that may be significant for patient. So don't write just in single line. Instead, write little elaborately like this in 1 or 2 sentences. Nicely written, Lekhana.
Yeah.
Good.
One thing, you can stomach cancer also you left.
Yeah.
Okay, you can add
we can add a pedigree chart also. That looks very impressive. Okay, 3 generational pedigree chart also we can include.
Colorectal cancer. Can you tell me one syndrome, Betty?
So it's Lynch syndrome.
Lynch syndrome and some other thing. HNPCC. Have you heard?
Yeah, it's also called HN. Yeah.
Right. Very good. This slide. This one is extra. For this itself, I'll give you more marks. Okay, go to the next slide. This I told you when the next time when you present, and you just mention the age summary, that is enough. Don't bring the diagnosis here, because without palpation, without clinical, see, the clinical examination, other thing, you cannot come to a benign condition. Okay, it could be you cannot bring this one. You see, on the basis of the history taken, the probable diagnosis could be a benign lump in the breast.
Okay.
Why it's benign, Lekhana? Why you think at the end of history, what are the points in favor of a benign lesion now?
So there was no history of weight loss, or there was no history
from the beginning, from the day. See, when we ask something, you should come in order like this. From the starting from the patient's particulars, what are the points in favor or to rule out? See, come in order, okay?
Yes, sir.
Coming from the gender, age, duration, like that. Okay, so it will be so that why? See, you can answer anyway, but if you answer in order, it will be the chance of missing out this is very less. Okay, any points, important points. Okay.
Lekhana, anything if they ask you why do you say the diagnosis, you say it's young female, 14 years duration, so 21 years, 3 months duration, with no other any comorbid conditions, you can say. So I think probably think it could be a benign. Always start from the age.
You summarize. Start answering that, Lekhana.
Okay. So a 21-year-old female who came with a chief
lady,
complaint
not female. Lady, she is.
Okay, lady. Yeah. Who came with a chief complaint of a lump in the upper outer aspect of her left breast since 3 months, which was not progressive, which was not associated with any pain, then and she also had no history of any trauma. Then she also complained. I mean, there was no history of bone pain or anything like suggestive of distant
discharge. No discharge. Okay, and there is no any family history. These are the things to bring in. So I said probably a benign one. That's enough. You need not write all the things. Okay.
Yes, sir.
Go to your clinical examination.
Yes, sir. The general physical examination, the patient was examined in sitting posture in adequate daylight with proper informed consent. The patient is conscious, cooperative, and is well oriented to time, place, and person. The patient is moderately built and well nourished. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema are absent. Vital signs: BP 110 by 80 mmHg, respiratory rate 12 breaths per minute, temperature 37 degrees Celsius, pulse 68 beats per minute, BMI is 22 kg per meter square.
Okay. Now, since you are a female and it's a female, you didn't say that in the presence of a female attendant. Yeah. But usually you mention it, no problem. Okay. Nothing wrong in putting
Most important is informed consent. Okay?
Yes.
Informed
consent is very, very important. Okay, you have to explain what you are doing before to the patient, and you have to give the reassurance. If anything happens, if it's pains and all, please let me know. Okay.
Another thing is, if the patient is from some other state in her own language, okay, that is you can write it if necessary. It's not necessary. Okay, come to your next slide. These are all general examination.
So the local examination was done with the consent of the patient with adequate.
Fully done. We'll come to the slides. Okay, you present full. Come.
Sir.
You present all these slides, then we come to back.
Okay, sir. The local examination was done with the consent of the patient with adequate exposure and inadequate light, with the patient in sitting posture. Inspection of the breast, the position of both the breasts are normal, which are bilaterally symmetrical, which show no puckering or dimpling. The left breast has a small lump in the upper outer quadrant, measuring approximately 2 into 4 centimeters. The skin over the breast has a normal color with absent engorged veins with no dimple or puckering, no ulceration or fungation. The nipple is present on both sides, which are symmetrical. The position of both the nipples are at equal levels, approximately 15 centimeter from the clavicle and 11 from the midline. There are no accessory nipples seen, no discharges present from them. The surface looks normal. The areola appears dark in color with the surface being normal. The arms and the thorax also look normal. The axilla looks normal with no swellings. On asking the patient to raise her arms above her head, the submammary folds are visible and they appear to be normal. Palpation, there was no local raise of temperature and tenderness on both the right and the left breast, but there was a lump in the upper outer quadrant of the breast, which was 7 centimeters below the clavicle, 1 centimeter from the anterior axillary fold, and 9 centimeter from the sternal border, which was at approximately 1 o'clock position. It was a solitary swelling on the left breast, which was a globular lump measuring around 3 into 4 centimeter in size, which was smooth, well defined with regular margin. It was firm in consistency. It was not fixed to the skin, not fixed to the breast tissue, and it could hence be moved easily within the breast substance. It was not fixed to the underlying muscle and to the chest wall. On palpating the nipple, there was no discharge present and no ulcerations were seen. Examination of the lymph nodes, of the axillary lymph nodes, there was no lymph node swelling seen in the pectoral, brachial, subscapular, central or the apical group. The supraclavicular lymph nodes also, there was no swelling seen. General systemic examination, CVS S1, S2 heard, no murmurs found. CNS, no focal deficit detected. RS, normal vesicular breath sounds heard. Per abdomen was normal. Spine examination was normal. Per vaginal and per rectal examinations were also normal.
Yes, come to your first this slide, the slide was very good. So there are various positions of examining a breast. Tell me the various positions of inspection and palpation.
Sir, it would be sitting posture,
semi-recumbent,
semi-recumbent, then recumbent position. Yeah.
And with some slight manners with the hands and.
See, inspection, you have three things. One is sitting position, okay. Number two, with the arms raised above.
Hands above the head.
Arms raised above. And the third one is bending forward. That is inspection. Palpation, you have the semi-recumbent. Semi-recumbent is the best position for palpating. It is 45 degrees. Recumbent is done in a huge pendulous breast or a fat lady where you keep a pillow underneath the breast and palpate the breast over the chest wall. So recumbent is another position. Palpating on the hips, one. Okay, palpating against the wall. So these are the various methods you palpate. Okay. Now inspection. Okay. Inspection recommend is another question. Formal. Okay. Palpating against inspection. Symmetrical contour of the breast, size and shape of the breast. You said bilaterally symmetrical. That is enough. So position. If the affected breast is at a lower level than the opposite breast, what do you think of? My question number one. If the affected breast is a higher level, what do you think?
Sir, if the affected breast is at a lower level, it could be like a phyllodes tumor, anything that's heavier.
You said benign. You just say simple word is you don't confuse. Say it could be a benign tumor. Benign tumor. What happens is the breast is not fixed, so it starts dragging the breast tissue and it falls forward. Right. Size and shape bilaterally symmetrical. If the affected breast is at a higher level, that means it is fixed to the underlying tissue, so it could be a malignancy, probably. Okay. Now you see a huge breast. Some disturbance in the back. Somebody has to mute themselves. Yes, Lekhana, what are the causes of huge breast?
Yes, sir.
Yeah.
Huge breast, sir.
Giant.
So it would be phyllodes tumor, giant fibroadenoma.
Good, very good.
Then a carcinoma, sir.
Which type of carcinoma? Colloid, I'll tell you for 5 reasons. One is giant hypertrophy of the breast. That is a congenital condition where it is bilateral. Okay. If it is unilaterally, it is a huge one. It could be a giant fibroadenoma, a phylloid tumor, a sarcoma of the breast, which is very, very rare, colloid carcinoma of the breast. And lastly, you can think of filarias of the breast, which produces a huge weeping type of breast. Okay. So these are the things which can produce giant swellings of the breast. Size and shape are bilateral, it is symmetrical. Very good. Now the puckering or dimpling, you said, isn't it? That you can come when you come to the skin over the breast. When you see when you see the breast on inspection, position, size, shape, contour, the position of the nipple, you have said very good. The puckering and dimpling, you come onto the when you say the skin over the swelling. Okay. Now, what is the meaning of puckering or dimpling or tethering? Is it the same or not? And what is it due to?
Sir, it's due to the infiltration of the ligament of Cooper, sir.
Right. What is puckering? What is dimpling? What is tethering?
So it's all the same. It's a synonym. It's a synonym.
Neuro hacker, you have to change your answer. Yes, mention lymphatics. They got some good names, Kishan.
Yes, sir. Amphetamine also is there, sir. Attending our session.
Amphetamine, I do not know who's it. Is it a hack? Is it really hacking us? I don't know. Please change your names, my dear Beta or Betty. So, dimpling, puckering, all.
They are not proud of their names, maybe. They're happy. They're not happy with their names.
Neuro hacker again. Sorry, sir. No problem, but change your name. It is. I'm afraid that you'll hack my computer. The puckering, dimpling, and tethering are almost the same. Puckering and dimpling depends. If it's a small single early case, you'll have a puckering, dimpling. Puckering is when 2 or 3 bunch of Cooper's ligament, there will be a depression. That is called puckering. And tethering is nothing. When you palpate the dimpling and puckering, you feel a tethered sensation. That's called tethering, but it's almost the same. Okay. The breast lump may not be fixed to the any tissue or not have any changes. But dimpling and puckering, if you see, means it's a malignancy, it is infiltrated. Now, skin over the breast, what are the things you see in the skin over the breast? You said color and texture normal. What are the other things? You have already mentioned puckering and dimpling. Yes, what are the other things you look for? Engorged veins. Engorged vein. You're right. Where do you get dilated veins over the breast tissue?
Sir, in phylloids, in sarcomas.
Sarcoma of the breast is very commonest one is phylloid tumor. Yes, yes, some Ravish Bhatte. Very good, Ravish Bhatte said that is Monder's disease is not dilated veins, you will get a cord-like thickening that is called the superficial thrombophlebitis of the veins. Okay, engorged veins absent, dimpling and puckering you mentioned here. Again, you mentioned here, no problem. Now next. Lateral thoracic vein, superior epigastric vein, thoracoepigastric vein, all these veins. Sanjay, very good. The 3 veins are there. Go to the neck. Now, you said that is in this sitting position you have to listen. No, nipple, presence of nipple, both the nipples. What is the level of the nipple, ma? Lekhana? She's gone, huh?
So at the level of 4th intercostal space.
But nipple, the breast, okay, breast extends from?
Second to 6th. Second to
medially?
6th.
Medially?
Medially from the sternum to the mid-axillary line.
Very good, very good. So you said no accessory nipples, no discharge present, nipple. Now, what are the important history you will ask in nipple?
Sir, any discharge is
discharge is one. Yes, discharge is one. Anything?
So then we look at the surface, whether it's normal or whether it's eroded.
Suppose the nipple goes inside. Yes, very good. Prajwal is retraction. Yes, very good. Sureka, recent retraction. So, retraction of the nipple is there. If the retraction of the nipple is there, the main history you ask is it recent retraction or long-standing retraction? Why? If it is recent retraction, it is due to the malignancy. That is infiltration of the lactiferous duct. If it is long-standing retraction, probably the patient may be an convergent congenital inverted nipple. Okay, that is why you ask for the retraction. Discharge. If you see
how do you
the
differentiate
discharge,
between two, Lekhana, congenital and the recent one? By patient may not be able to tell something. So can you demonstrate how to differentiate
Yes,
between
sir.
congenital?
Yes, sir. So
yes.
around that retracted area, when we press from either side, if the nipple it comes back to its original position, it would be congenital. If it does not, then it's then it would be malignant.
So in types of in the retraction also there are some types. Looking at the types only you can tell what's the diagnosis. Do you know anything like that?
Sir, I know one like slit-like retraction would be ductal ectasia.
Okay.
Or periductal mastitis you get.
Yeah.
C for C you remember. Circumferential retraction you get in carcinoma.
Carcinomas.
C for C. Now what are the changes in the nipple? If you want, I'll tell you the D's, the 7 D's mnemonics, which was given in a book called Norman Brose. I think Kishan, if you read it, you know. Then it has Clinical Science in Surgery by Norman Brose. Okay, you can write it down. Depression, destruction, deviation, discharge, discoloration, displacement, and duplication. It is almost the same only, but the 7 Ds he had mentioned. I'll repeat: depression, destruction, deviation, discharge, discoloration, displacement, and duplication. It comes in alphabetical order. So you said no accessory nipple seen, no discharge present. The areola appears normal. Where do you get dark color areola? What is the
So during pregnancy.
What is it? You get some elevated spots in the around the areola. That's called Montgomery's tubercle. Underneath, you have the Montgomery's gland, which is a lubricant surface. Okay, right, surface of it. These are all you look in the sitting position. Now you raise neck. Go to the next slide.
Destruction of nipple. Where do you see the destruction of nipple?
Then Paget's
So could everyone write down all the 7 points? Or else, sir, can you please repeat? This was very important and useful, sir. Can you please once repeat all the 7 points?
I told you, depression.
Because UGs love these kind of mnemonics. Nobody will tell them.
Depression. It comes in alphabetical order.
Please,
Depression.
write down. Okay, notes.
Destruction.
Where do you get the destruction, Lekhana? What condition? Give one example for each also, Lekhana.
Yeah, depression is retraction, ma. Destruction of the
Paget's disease, sir.
Paget's disease of the nipple is actually not a disease of the nipple. It is the subareolar carcinoma. Carcinoma which destroys the nipple.
Disease, sir. Destruction.
Yeah, Paget's disease. Destruction. Deviation is if you have a lump in the subnipple areolar region, it's a benign one. It takes the nipple to the opposite side. Okay. Discharges, I told you, discharge. Discoloration of the nipple you may get in, as you said, in pregnancy. Displacement and deviation are same. Sometimes you get accessory nipple, that is duplication. To repeat: depression, destruction, deviation, discharge, discoloration, displacement, and duplication. Okay. Now the arms and thorax normal. Axillary looks normal with no swellings on the patient on the hands by the side sitting. Now ask the patient to raise the arms for 2 reasons. One, if the lump is there, it becomes more prominent. If the lump is not there, what happens is the lump will become prominent on raising. Okay, you understand? If the lump is present, it will become more prominent. A lump which is not visible may become visible on raising the heads. That is point number 1. And point number 2, to look for the inframammary folds. You have said subvisible. Okay, these are the things you do on the raising. Now, on inspection, you have to look for, ask the patient to stand and ask the patient to bend forward, and you have to see the falling forward of the nipple, falling forward of the breast. You also have to bend down and go tangentially in line with the breast tissue. Okay. So when you go in line, you can say if the affected breast doesn't fall forward, it indicates that it is fixed to the chest wall. And chest wall is intercostal muscle, ribs, and serratus anterior. not pectoralis major. Underline that word. Fixity of the pectoralis. Now, you have come to the palpation. You have drawn a beautiful chart. Palpation. Generally, you take it to the semi-recumbent position. Take the breast to the, you're feeling a lump, isn't it? Put it over the chest wall and start palpating. While palpating, you look for local rise of temperature. Then the characteristic of the lump. Lump in the which quadrant? You mentioned very good, 7 centimeter. Surface appears. You come to the next slide.
Yes, sir.
Nicely written, but it's a unique way, nicely written. Another better way is schematic representation. Make a rough diagram, like sir told, 4 quadrants you show in a circle and with some axilla, and in that point out where exactly it's okay. It's a better, still better.
Yeah,
It all
always
gives
diagram.
more impression to the examiner. Okay, and exact situation can be made out with diagram.
This will practice
In the
not only
provisional diagram, you can include or here also.
yeah, this practice not only in surgery, you practice in all the subject. You draw pictorial. When you write theory, we are correcting. So you saw that we see the picture, we get impressed, and we don't see the theoretical aspect.
Yeah,
And give
like you
that.
mentioned the clock and all. See, it gives a particular exact location. Okay, we get a fair idea.
Yes.
Good
Somebody
way,
with
good thinking.
ABC. Could you please repeat chest wall? Yes, it is intercostal again. ABC. Nice names, Kishan. Chest wall is intercostal muscle, ribs, and you have the serratus anterior, part of the serratus anterior also. That is called chest wall fixation. You have to ask the patient to bend forward. You also have to bend down and see whether in the broad daylight, whether it falls forward or not. Now, palpation, you said it's a globular lump. It cannot be a globular because globule means you have to see the whole circumference. So it could be a hemispherical or semispherical, smooth surface, well defined. Here, I don't think margin. I think border only will come, isn't it, Kishan? Margin.
Both margins, you can use
Yeah.
either one. Okay, margins mainly for ulcer and all you can use here. Okay, any one.
You said fixity to the skin. You said not fixed. How did you look for fixity to the skin?
So we pinched the skin overlying the lump. It was able to be pinched out, and then we moved it over the lump as well. That was also possible.
So not fixed to the breast tissue. So the fixity to the breast patient will not have any other signs. Only a firm lump. Even a malignancy can be a firm lump, but only classical differentiation between a benign and malignancy is fixed to the breast tissue. You catch hold of the breast tissue in one hand, catch hold of the lump. When you try to move the lump, the breast tissue also moves. That is the early sign of malignancy, or it may sometimes involve the Cooper's ligament. Okay, so it is not fixed to the underlying muscle. So, better way this you've said fixity. Is it fixed? My question is it fixed to the pectoralis major? How did you look for fixed to the pectoralis major?
So we asked the patient to keep her hands over her hips, and then we see whether the pectoralis major is taut or not by seeing the prominence of the anterior axillary fold.
Feel, not see.
By feeling the prominence.
No, you taut. It should be taut.
Yeah,
you're answering like a typical exam going PG. Wonderful.
I will tell you, you're very good. I'll tell you, you should keep the arms on the hip, catch hold of the lump, move it in the opposite direction along the line of the fibers. Along the line of fibers is it goes and gets attached in the bicipital groove. So along the line of fibers. Then ask the patient to contract. When you know, how do you know the hip pectoralis major is contracted? Is you look at the anterior axillary fold, feel for the tautness, then move. If it doesn't move along the line of the fibers, it is called fixity to the pectoralis major. And mind you, that is not fixity to the chest wall. Okay, most of you mistake it. So fixity to the chest wall is a inspective finding. You have to look forward and see. Also palpation, you can bend forward again. You can see. Yes.
Here
yes,
you
Christian.
written fixity to chest wall. Okay, you written fixity to not fixed to underlying muscle. Can a lump can be fixed to chest wall, not fixing to the muscle? Is it possible that way?
Can it fix to the chest wall without fixing to the muscle, sir?
Yeah. Yeah.
I don't know.
No, the posterior surface is formed by the pectoralis fascia and pectoralis muscle.
By the
In
pectoralis
between,
fascia.
yeah, in between you have a retromammary fat tissue. Okay, it has to
Yeah.
get infiltrated, get fixed to the pectoralis major, then fixated to the chest wall. That comes in malignancy. The staging and all we'll take when we take about breast carcinoma. Okay,
So here
not
chest
this.
wall doesn't, the fixated chest wall doesn't occur on come only to the okay, because it's not at all fixed to the muscle. Okay, without fixing to the muscle, it will not go beyond that, right?
Let's go to the next.
So unnecessary things don't.
Yes, you said ulceration, isn't it? Why do you get ulceration?
Sir, it can also be seen in phyllodes tumors, sir, as a pressure necrosis. Otherwise, we see it in carcinomas.
Carcinoma. Now you have told me, I have to ask you a PG question. Now, there is an ulcer. How do you differentiate whether it is a malignant ulcer or, yeah, Dr. Strange, who is that?
Sir, by probe
Before question only they'll answer.
Yeah, by probe test, sir.
Yeah,
yes,
good.
correct. Probe test, very good.
How do you do?
It's not a see, some people do not answer. That is why I said no problem. By probe test, okay. That is due to pressure, whereas in malignancy it is due to the infiltration. What are the other skin changes you can get, ma? If you come under stage T4A or T4B, what are the skin changes? T4B means skin changes in a breast carcinoma. 3 points are there. Yes, what are they?
Sir, discoloration.
No.
Satellite nodules, sir.
Very good. Satellite nodules, purely orange, ulceration. Okay, these are the 3 things. Cancer and crusade, please don't say, pa. Then if you say as in purely orange, why do you get purely orange?
So it's due to the lymphatics being obstructed.
Classical is subdermal lymphatics.
Subdermal
with infiltration of these glands. Okay, or the subdermal glands. So what happens is that glands go inside, the hair follicles go inside, that will produce the purely orange, and the thickening is due to the subdermal lymphatics, that is called purely orange. That is classical of malignancy. Okay. Yes. Go to the next slide, ma.
Yes, sir.
Examination of axillary lymph nodes, no lymph nodes seen, you said, no pectoral. Now, what are the lymph nodes examined from front? What are the lymph nodes examined from behind? You have been taught, isn't it?
Sorry, sir, I didn't get your question.
No, what are the lymph nodes you palpate from the front? That's, I said this patient has got a left axilla.
Yes,
How do you
sir.
palpate the left axilla?
So the left axilla, it's only for the posterior subscapular. That's a the subscapular lymph node we palpate from behind. The others we palpate from the front, sir.
Even supraclavicular you can
Even the
palpate.
supraclavicular also from behind.
Right. Front left axilla. How do you palpate from the front?
Front left axilla, you stand on the right side and then we use our right.
Right hand. Where is your left hand?
We use our right hand.
Your left hand, and the patient's hand, where it will be?
Sir, it rests on our forearm.
Very good.
Whatever we are using for
and your left arm,
it rests on our forearm.
And your left arm?
Sir?
And your left arm?
So the left arm is to support the patient, like to hold the patient still.
Put it over the shoulder joint. Depress the shoulder joint so that the axilla becomes diamond shaped. So it relaxes the axilla.
How do you palpate the lymph node? Can you show, please? With your, how do you really palpate? Can you please show?
So we palpate
Just
it
demonstrate
with
us. Just demonstrate. Yeah.
Yes, sir. So we palpate it with the palmar surface of our fingers, sir. We insinuate it inwards.
Three fingers, middle 3 fingers. Okay, with the pulps of the middle 3 fingers. Okay. Okay. Not with the entire palm or not with the entire hand.
Yeah. You go up to the apical.
It holds good for all examination.
You go up to the apical, come down central, anterior, lateral. Where do you palpate?
So lateral is palpated against the head of the humerus.
Very good, very good. Supraclavicular. So supraclavicular, infraclavicular, you said. What is that interpectoral nodes are known?
Rotors nodes.
What is that Halstead's ligament?
I don't know, sir.
It's otherwise called the costoclavicular ligament.
Oh.
Very good. Ravish Bunny. Very good. Ravish Bunny. Very good. It's called the costoclavicular ligament. That means it is go. If you have to cut the Halstead's ligament and go means it is the apical group. That is, it goes into the level 3 lymph nodes where the prognosis is bad. Halstead's ligament. Okay. Now you have no lymph node swelling. All other systems normal. Now summarize.
Sir, I have the summary like at the end, sir.
Yeah, you put.
Okay, fine. Yeah.
I'll put that. Yeah, over here. Do I read this out, sir?
Yeah, you read it out.
Okay. Clinical examination, it revealed a small, painless, firm and mobile mass measuring 3 × 4 centimeters in the left breast without nipple discharge, inflammatory signs, axillary or supraclavicular lymphadenopathy. The right breast and nipple were normal and systemic examination did not show any abnormality.
Okay. So this, based on your clinical examination, you say it's benign swelling. The commonest benign swelling, what is that called, which moves freely within the breast tissue?
Fibroadenoma, breast mouse.
Breast mouse. So it could be a fibroadenoma. Okay. Now you have to do what was the size you said?
Sir, it's 3 × 4 centimeters.
Right. When it crosses 5 centimeter, what is it called?
It's called a giant fibroadenoma. Giant
fibroadenoma. Yes. Now, how do you want to proceed further? Do you have any differential diagnosis apart from it's a benign one? The benign one, you have any other differential diagnosis? Now you bring you show your ultrasonogram for no problem. You did an ultrasound mammogram or ultrasonogram?
It's an ultrasonogram, sir.
Ultrasonogram. Will you get any type of calcification in a benign swelling?
No, sir.
You get popcorn calcification.
No.
It will be
no, when he's telling you get it's a clue. Sir is giving a clue. Okay. If you're getting anything, you should yes. See, I'll tell you, Lekhana, you'll not get a sweeter examiner than this. He's like
yes,
nobody will spoon feed like this. Okay. Don't expect this much. Okay. Anyway, it's a nice way of learning for us, but exam will not be like this.
Some people are answering. Kishan Sanjay has answered popcorn, fibroadenoma. See, in malignancy, you will get microcalcification. Okay.
Yeah.
In benign, you will have a popcorn calcification. Mammography, that and all. He said we'll discuss. So you come to a conclusion. It is a benign swelling, ultrasound well circumscribed lesion. Now, would you like to proceed further? What is the next line of investigation? Would you like to do?
So it would be FNAC, sir.
You want to do an FNAC, epithelial cells and bioepithelial cells. See, it's a good slide.
What is FNAC, Lekhana?
So it's fine needle aspiration cytology.
Okay.
Okay. Suppose you have a fibroadenoma. You want to do any other investigation?
No, sir, because it's already benign and we know that it's a benign. So I don't think we would go for true cut again.
Right. So in the exam, you will not be given this slide. You will not be given an ultrasonogram. You will be stopped short at the clinical examination, and you will be asked to proceed further. So
which
you said,
does this belong in a BIRAT score?
So BIRAT score, it's breast imaging, radiation and data system.
This your diagnosis falls into which category?
Sir, it falls into grade 2.
Of BIRAT?
Grade 2 of BIRATs.
What is thyroids?
Sir?
Thyroids.
Thyroid.
TI.
The same thing for thyroid.
Thyroid, like just like
now recently CORADS has come, you know.
Okay.
CORADS for CT scan for corona. I will send it to Kishan or I'll send it in the group later. What is CORADS? Grade it accordingly. So you come to conclusion now. Suppose you don't have a picture of the fibroadenoma, FNAC, you don't have a picture of the ultrasonogram. You stop short with one diagnosis, or you want to offer a differential diagnosis? He was asked to discuss about benign conditions. Okay, I say it's fibroadenosis. How do you rule out? We will rule out one by one. Fibroadenosis.
Sir, it can't be fibroadenosis because we've ruled out that pain during menstruation. There is no cyclical mastalgia at all.
No, not only cyclical mastalgia, you will not have a definite lump like this. You have to feel it, you palpate with the palm of the hand, you feel a granular surface, and you will not have a typical lump like this in fibroadenosis. And okay, right. Can
no
it be
well-defined mass? Okay, there very irregular. This thing will be there.
no, number
mass.
two,
Maybe multiple also.
Multiple also.
Yeah.
Number two.
And second bilateral most of times it is.
Yeah.
Number two, can it be a breast abscess?
Sir, she gives us no history of any pain before or anything. If it was a breast abscess, it should have been assessed.
I told you your diagnosis. I'm asking you because I'm not taking away from your diagnosis. I wanted you to know about other things. Okay, breast abscess
yes, sir.
is not warmth, not tender, is not cystic in consistency. She was not put on any drugs, so it cannot be an antibioma. So it is not a breast abscess. What is the peculiarity of the breast abscess? Okay, define abscess, ma.
Sir, it's a collection of pus.
Somewhat specific. Since we talked about abscess, I will finish in 5 lines. Abscess is a cavity containing pus lined by granulation tissue.
Okay.
That is why when you drain an abscess, the abscess cavity is closed. When do you drain an abscess?
So when the pain is more.
No. What is the sign you elicit for draining an abscess? Sign of fluctuation. Ravish Bunny, I don't know from which college. You mentioned from which college in the chat box. Very good. The sign of fluctuation. That means the pus inside becomes liquefied. Then only you have to drain an abscess, the pus will come out. BMCRA. Oh, I do not know what is BMCRA. Bangalore Medical College. Your college, huh?
Yes,
your
sir.
college.
BMC.
No, Ravish Bunny is your college. No, that is you don't wait. You wait for the fluctuation and drain. That is, pus becomes liquefied. So when you drain an abscess, so what are the areas where you don't wait for the sign of fluctuation? There are 5 areas. I'll tell you. I'm showing my hand also. And the reason why.
Lekhana, you got the question, no? There are some cardinal features of abscess, like pus pointing.
Ravish quite slow. Or Lekhana will see that and tell the answer.
And abscess can occur anywhere in the body, but in some places, particular places, we don't wait for the fluctuation to occur. Immediate before that, we drain the abscess. Anywhere in the body there is pus, we have to drain. But in some places, we don't wait for the fluctuation to occur. Okay, we immediately have to drain. Which are those specific places?
So like in the brain?
No. I'll tell you. Palm, soles 1, parotid 2, breast 3, palms and soles 1 and 2, parotid 3, breast, ischiorectal abscess. In this palms, soles, and parotid, you cannot elicit the sign of fluctuation because of the tight fascia. Parotid, you have the parotidomesenteric fascia, you cannot elicit the sign of fluctuation, and it will be severely painful. Breast and ischiorectal abscess are very painful, so as soon as you decide, you find out it's an abscess, time to drain it. And what type of drain you put in breast abscess?
I don't know, sir.
Usually you put a dependent drain. Here you put a non-dependent draining of the abscess. Okay. So abscess we can take one day separately. So it is not an abscess. You ruled out abscess, you ruled out fibroadenosis. Any other differential diagnosis you want to put?
Sir, again, ductal papilloma.
Ductal papilloma. What is the classical thing of ductal papilloma?
Bloody discharge from the nipple.
Bloody discharge. So if it's a ductal papilloma, what is the confirmative study to see whether it is ductal papilloma?
So contrast mammography.
No. Anything else? Somebody says, why not in parotid? Because parotid, the deep, Deep fascia, this is a perotidomesenteric fascia. Somebody's asked a question. Perotidomesenteric fascia, which is attached about to the zygomatic process, is a tight fascia. You cannot elicit fluctuation. Why non-dependent drain? Because the breast is hanging down. It keeps on. Sometimes you may get a fistula formation. That is why you do a non-dependent drainage and put a wig inside and keep it. That will we are going away. Now you said what is what ductography or galactography, where you inject a dye and you can find out. Now you have a lot of other things. You have to cannulate the duct, inject the dye, and that. If it's a duct papilloma, what is the treatment you give?
The microdocectomy.
Now the answer should be: is it from a single duct or a multiple duct?
Yeah.
Ductectasia, multiple.
If it's a single duct, it's microdocectomy. If it's multiple, it's that cone excision.
What is the name cone excision? Hadfield's cone excision, right?
Hansfield.
It's too good for third year, sir. I'm really.
No, I think you know. You coached her. Hey, don't you are now. Kishan is. He told everything. Yes, taught already everything. Very. No, you're done. You're doing very good. Excellent. So it is not a ductectasia or duct papilloma. What is the next diagnosis you put?
The phyllodes, if it's like a low grade phyllodes.
You don't say low grade, high. Low grade or high grade means then I will go into the next question. What is low grade? What is high grade? What is
pathological? You don't tell pathological diagnosis here, only clinical diagnosis. Okay.
So we examiners are very bad. You take us means you are taking us.
You may be right. Okay, but here we are discussing only clinical part, right?
Right. You say phylloid tumor. If you say low grade, then I'll say what is low grade, what is high grade, what is Paddington's criteria, what each criteria I'll go. Keep on asking. So don't say. So it could be phylloid tumor. Why you don't say it's a phylloid tumor?
Sir, because it's not very big. It's not that it doesn't have that bosselated appearance.
Very good.
Yes, bosselated. So
and there were no dilated veins over the skin.
You may not get it.
Okay. Why dilated veins? There were no ulcers or any pressure necrosis.
Lekhana, why do you get dilated veins?
Sir, it's mainly because of increased vascularity there,
Very good, wonderful. Okay, also sometimes because of the compression of the.
Because the phylloid tumor is
compression, artery because of vasodilation, like vascularity, increased
vascularity. Because previously they were telling cystosarcoma phylloid. Now with the term sarcoma is now just a phylloid tumor. The classical the explanation, as I said, increased vascularity, and since it's a benign tumor, it will not infiltrate the blood vessel. It gets compresses the blood vessel and splays the blood vessel, so you get dilated vein. So the classical point will be: first, it will be a huge breast. One. Number two, bosselated surface, variegated in consistency. It will have various consistency. Some areas it will be firm, some areas it will be cystic. Okay, there will be no skin changes, no axillary lymph node. These are the 5 points. Okay, big breast, bosselated surface, variable consistency, no skin changes, and no axillary lymph node. Suppose you have a phylloid tumor diagnosed clinically, you have an axillary lymph node. What do you think of?
So that it's converted into a sarcoma.
No. Sarcoma travels by lymph.
Through hematogenous.
Some infection.
Okay.
Just simple answer: infection.
Secondary infection. Okay.
Secondary
so
infection.
You have to give antibiotics.
So this patient, cystosarcoma phylloids is ruled out. So you are coming to your only conclusion is fibroadenoma. You are done up FNAC. You are confirmed. What are you going to advise the patient?
Okay. Sir, there's no treatment.
Surgeon now. Lekhana is a surgeon. Okay, what will you assume yourself a surgeon, Lekhana now. Now what you'll say to your patient?
So actually, there's no treatment required unless associated with any suspicious cytology
to the patient. What will tell? You don't tell us. Your patient is sitting in front. Imagine and tell what you. Okay, let's see how good you are at counseling.
Okay, so the first thing that I'll tell that you don't require any surgery for this, as it's not really harmful to you. But if I do get a FNAC cytology that is quite suspicious, Or if the patient herself is asking me for some cosmetic reasons that it has to be removed, then we could go with enucleation surgery or cryoablation or heating with a high frequency ultrasound.
High frequency ultrasound, all these things. The classical one is, as you said, enucleation surgery. Indications is one is if it increases in size, it will become a big one. It hinders with the normal activities. One. So it is upper outer quadrant, you said. Suppose if it's in the inner quadrant, it is and it's an unmarried lady. Definitely, you advised her surgery. Okay, that is the. You try to remove it when it is small. Preferably, if it's very less than 2 centimeter, you can wait. Now you say almost it's 4 centimeter, and it has been increasing in size. You can advise. You are correct in your advice that it is not necessary. But if it increases in size, it may be difficult. So you do a surgery. You do an enucleation. No, the cryoablation and all. Yes, I'm not very popular. Kishan can highlight on cryoablation.
Sir, like no, we'll discuss with the surgery, sir, today, like two type, like excision and enucleation. Because those are not commonly used. There's only theoretical purpose, and in the surgery we will not ask those questions for UGs.
UGs, I'll tell you, heating and all. You don't say. You say you do enucleation. That is living behind the capsule.
Whatever available in your when we are answering, no, whatever available in our setup, we should answer. Okay, ideally, what we do in our hospital, that should be the first answer always.
Yes, sir.
Okay.
You should say in our institution, whatever is your reply should be for your patient.
Okay.
Yeah, for your patient, what you do.
And for in your institution, what you're doing. No examiner will oppose. What I am doing in my institution or what I am doing in abroad or what people do in Northeast, you should not say. You can do an enucleation that is leaving behind the capsule, or you can do an excision along with the capsule. Okay. That is what you can do. Okay. So this is the treatment. And you mind you, there were two school of thoughts, intracanalular and pericanalular, which is not anymore taken now into consideration. And fibroadenoma as such never turns into malignancy. So you remove the chance of recurrent fibroadenoma. Right. Now, when you have the patient is on you with you, you want to plan the patient for surgery. What is the incision you put?
Sir, we could put a circumareolar incision.
So,
it's a lower. Okay. If it's far away from the areola, then what do you do?
So then we put an incision towards that wherever.
All the ducts go and emerge the areola, isn't it?
Yeah.
So near the areola, circumareolar, you put it away from the areola. One is the Gaillard-Thompson, who is Gaillard-Thompson incision is submammary incision of Gaillard-Thompson incision. That you do for what?
So for fibroadenosis?
No, fibroadenosis, I don't.
What's the treatment for fibroadenosis?
Yeah, I wanted to ask.
Sir, initially we give them drugs, sir, but if it doesn't...
Amphetamine?
Like bromocriptine, danazol.
Before that, commonly used? Because I want to make it clear, because many have the misconception about that. That's why. Someone answered already. Look at that answer, tell.
Even tamoxifen they use bromocriptine.
Evening primrose oil. Evening primrose oil.
Right. Evening
and
primrose
it's not oil. Okay. It's not oil. It's a capsule.
Yeah.
What does that do? 300 to 500 mg we give. And what does that do?
Sir, it converts the saturated, some unsaturated to saturated. Yeah.
Very good.
What does it contain?
Ganolinic acid.
Ganolinic acid. Do you know why it's called the evening primrose? It's a history. It's taken from that. I forgot the botanical name. That actually opens up, blooms only in the evening and closes. It takes in from that one. That is why it's called the evening primrose oil, ganolinic acid. Okay. Some history is very important. It's very interesting. So one is you can give
medical management fibroadenosis. Only if there is intractable pain is there, okay, non-bearable, then the patient is very apprehensive. Only then we go for excision, okay, not otherwise. Yeah. Don't tell, okay, for fibroadenosis and all.
And primrose oil is costly. You have to give at least 3 to 4 grams per day for 3
vitamin
to 4
E and all should be given. All those very costly.
Okay, so that is one thing. First is reassurance. You can give the patient will adjust the inner wear, okay, and you give the reassurance. You can give some painkillers. Patient will subside. They usually get during cycling mass. Patient will come out of it. Otherwise, if it's intractable pain, you give. Still, is there means you can go in and do the excision, but the excision with followed by biopsy. Okay, right. Nipple. So we have come to fibroadenoma. We have finished everything. If it is phylloid tumor, what is it you do? The giant phylloid tumor. What is it we do? What is the treatment you want to do?
So excision.
Simple excision. If it's a
Yes,
huge
sir.
one, the breast is hanging down. Yes, one is wide
Then a
local incision.
simple. See,
Yes,
if it's malignant, then we can do simple mastectomy.
you can do a wide local excision. If
Oh.
it's old age people, if it's a large lump, if it is hanging down, pendulous breast is hanging down, you can do a simple mastectomy. Huh? But usually it is done only if there is a recurrence, you do a simple mastectomy. Otherwise, you can do a wide local excision. But in old age, why to repeatedly doing it, you can do a simple mastectomy straight away. In young female, but this lady will not have because young female. So fibroadenoma is your diagnosis. In fibroadenoma, the treatment is enucleation or
Excision.
excision of the tumor. Okay. Otherwise,
What is
your
cryoablation, you know, Lekhana?
Sir, we freeze the tumor, sir.
Insert a cryoprobe, okay, and freeze it,
what's the
okay.
temperature
And
use?
Sir, I don't know. Minus
That is
96.
what when you say something, it goes
yeah,
up to
that's
minus.
why you should be knowing everything about that if you're answering something, okay. Otherwise,
I
don't
think it's
mention only.
Huh.
Nobody expect you to do all this.
40 degrees. I think it's more than that. I'm not sure. I don't want to teach you wrongly. It is heating with high frequency ultrasound. These are all very good for very small tumors. But the tumor is more than 3 centimeters or something, preferably you remove it and keep it. Okay. Hmm? Okay. Shall we close today, Kishan?
Yes, sir. Yes, sir. It's a short case, and she has done wonderfully.
No,
And yeah,
you're passed with more than 80%.
no, sir. I'll give her more than 95. Because there is no question it
Yeah,
went unanswered by her.
Kishan, you don't underestimate it. I have given her 80 marks out of 70. Kishan,
That's clever, sir.
I given 80 out of 70. In long case we have your short case we have only 70
Sorry, sir.
marks here.
Sorry.
I gave 80.
But yeah, please don't expect this to be so sweet in exams, okay?
No,
Sir
no,
has
no.
taught in a very,
Everyone,
see, made you first see for each, why, just observe, sir, please, you close your ears. It's only for the students I'm telling. See, first he built a rapport with you. He made you comfortable in the, see, he simply didn't chat, okay? In the beginning, the two words with you that made you so free, so cool, right? Is it right?
Yes, sir.
Only experienced seasoned examiners, only passionate teachers will do that, not all. Surgeons are usually very strict and very try to be rude, okay, but it's one exception, okay, but don't take this for granted or don't assume it will be like this only always, okay. Only pray that sir will come as your examiner next year. That's all you can do.
No, to all the polls, you can stop cash sharing. If anybody is coming on the screen, I can say, see, undergraduate examination, we expect more of a clinical presentation. That is enough, man. A good clinical presentation and a probable diagnosis. That is enough. And wherever I go as an examiner, first I will not see the cases. I go and see the children. I say, I want to see my children. Sir, can we see? No, I will see them. I just introduce them and see. Don't worry. You tell what you want and something. And as soon as they come and sit in front of me, I'll ask their name. Where are you from? What are your parents? Did you eat in the morning? Or I'll offer them a biscuit which was given to us. This is so make you cool first, or else you will forget what you learned well. So that's why I wanted to see your face, and I said, this is for all the
And
students. Everybody is
best part of today's discussion was the student was very confident and answering very clearly without any hurrying or without any hesitations and all. Whatever she knew, she told clearly and perfectly and very confidently. That's what expected out of UGs and even for PGs for that matter.
Yeah,
Wonderful.
PG is also same only, Kishan. Your good presentation and the discussion will be more, ma. compared to the UGs. Discussion will be more, and they will find small points in it. Okay, why do you get pain in the breast? What are the reasons? There are a lot of things in it, but for your thing, you have done extremely well. Keep doing well, and I wish all the students to have the same kind of presentation. You may be doing the same thing. Okay, and I wish you all the best. Happy Janmashtami class.
Members.
Thank you, sir.
And
God
this
bless
Saturday
you.
we'll have another session by Professor Srinivasan sir and another HOD from KIMS Hubli, Dr. Kurujantha sir is also coming as a mentor to discuss about the thyroid malignancy. And probably next week or so we'll have another detailed discussion by sir on carcinoma breast. These are all very important, and you are learning directly from the seasoned examiners. So this will benefit you a lot, definitely. So don't miss those sessions. It's all arranged for you exclusively. Please take the maximum benefit out of these, okay? And the rich experience will also help you.